What is IVF and how does it work? This is one of the most important questions you can be asking yourself as you are on a fertility journey because IVF is one of the most powerful tools out there, even though it's not for everyone. I'm Dr. Preston Parry. I'm a board certified OBGYN and reproductive endocrinology and infertility specialist at Positive Steps Fertility. I'm going to talk you through the IVF process step by step, who it's right for, and what you can expect in terms of time, cost, and results. But as always, these are individualized and talk with a clinician as to whether this applies to you. So if you're exploring IVF or just want to understand what it involves, we're going to dive right into that. So first question everyone wants to know about is, okay, what does IVF even stand for? IVF stands for in vitro fertilization. So in vivo fertilization, in vivo means in the body, and in vitro means outside the body. So a lot of times when people get pregnant the old-fashioned way, through intercourse, or even are doing insemination, conception occurs not in the uterus. A lot of people think it's there, but actually in the fallopian tubes. And then the embryo, once it's formed, migrates from the tubes back to the uterus. In vitro fertilization, sperm and egg meet outside the body. They fertilize, then they often grow for about 5, 6, 7 days before you get a blastocyst. That's a high quality embryo. And then some will put it directly into the body. More often these days, people are biopsying, taking a few cells from what will be the future placenta, learning the DNA. And then once they get that result, they've frozen the embryo in advance, they get the result, then they thaw the embryo to put it back in the body. And this helps decrease a lot of miscarriages and birth defects by knowing the DNA for the embryo you put back. Why is IVF performed? The number one reason is if you've done everything else and it didn't work, guess what? You got to break out the big guns. You got to get something that's powerful and effective, and IVF is often that. And again, if people could get pregnant for free or easily, most people wouldn't do IVF. It's sort of like saying surgery. You don't send a person to the operating room if they're already healthy and well and everything's going according to plan. You do it when there's something going on that is complex and difficult. So prolonged subfertility. Now, some people, you're going to fast track. If you have your tubes tied, if you have your tubes missing, if sperm and egg just aren't going to meet, kind of important to say, let's not keep trying the old-fashioned way if a person doesn't have a fair chance at pregnancy. So who are other people who might not have a fair chance? Well, first, if a guy has very low sperm counts. So it takes 10 million sperm in an active intercourse for one to find an egg. While insemination can be a 20 to 50-fold boost, if you are under 500,000 or under 200,000, even if you did insemination, a sperm might not be finding an egg. That's where it's a lot easier to just take an individual sperm and put it directly in the egg. Another thing can be when the ovaries are scarred. So even if the tubes aren't open, the ovaries are scarred in a way that the tubes can't pick up from them. Sometimes you can do surgery to mobilize them, but other times you can't. Another reason a lot of people do IVF is because there are genetic issues they have to address. They have higher rates of miscarriage from abnormal DNA, and they're wanting to figure out which are the normal embryos. Or in particular, they have rearrangements of DNA where it makes for embryos that are likely to miscarry. This is called a reciprocal or Robertsonian translocation. And then sometimes people have genetic diseases they're trying to avoid passing on. Huntington's, cystic fibrosis, Tay-Sachs. Many conditions are out there that can cause pregnancy not to progress where the baby dies in utero because of complex DNA. And IVF can pick this up and help prevent them from being passed on. Another thing people ask about, what's the difference between IVF and IUI? IVF, again, in vitro fertilization, sperm and egg meet outside the body. IUI, intrauterine insemination. So the sperm is placed directly in the uterus, and then a lot of sperm are likely to find the egg. There doesn't seem to be an advantage to putting the sperm directly in the tube. Just by putting it in the uterus, 20 to 50 times more sperm find an egg than from intercourse. Usually that's enough. So if normally a guy has 8 sperm find an egg in a month, so 80 million total motile sperm, about 8 sperm will find an egg. If you, whether that's boost to 160 or 400, once you're starting to get beyond those numbers, really further precision doesn't matter. It's still plenty of suitors for that egg. And so there's plenty that reach the egg. Usually you don't have to do more than that in most cases. Another thing people want to know about is what happens during each step of an IVF cycle. And really, you can break it down into a few core components: synchronization, stimulation, retrieval, transfer. Those are the 4 core areas. And then, of course, hopefully, pregnancy itself. Synchronization, get the eggs lined up. Some people, this is more important than others, but there's some asymmetry to the eggs. So everyone thinks they lose 1 egg per month and they lose 900. You actually lose 30 eggs a day. And if one gets ahead of the others up here for size, it pushes the others down, and that's why people have a singleton relative to a litter of puppies. Well, if you stimulate here and you get this one to go forward, this one often will force you to get eggs out before these are ready. So you need a little bit of time and medication to get them all at the starting gate together. That gives you both quantity and quality. So there's the synchronization. Next is the stimulation phase. Most people are using injectable gonadotropins. This is Follistim, Gonal-F, Menopur. There are all kinds of brands involved in this, but they mimic the hormones naturally sent from the brain to the ovary, but in higher levels, to get a lot of eggs. Now, some people use letrozole and clomid or clomiphene to get the ovaries to grow eggs. Usually you only are getting 2 or 3 eggs instead of 15 or 20 or 25. And some people say, well, you're saving money on the medications with this min-stim cycle. And it's true, you do, but you're often only getting 1 embryo instead of 4 or 5. And if you're looking at costs, spending next to nothing on medications are 1/3 of your costs. But if you're spending 1/3 less, so 2/3 your total price, for 1/4 of the yield, for many people, that often doesn't make sense. So this is where min-stim often doesn't give people as much as they hope. Works right for some, but not for everyone. So you give the medications, you get the eggs to grow, and you say, okay, we've got all these eggs growing. This is a great yield. This is where I want to give you a trigger shot. And people use HCG, Lupron, a couple of medications for this. And about 35, 36, 37 hours later, people are retrieving the egg. We tend to use 37, by the way. We go a little bit longer, and we think that generates a bit higher quality. But you have to be very precise to make sure people come in at the right time and gave their shot at the right time, because you don't want them ovulating. And then they come in, they get anesthesia. Some people will do local blocks or conscious sedation, or some go as far as propofol, which is a deeper level of sedation. What is an IVF cycle? So again, if IVF is in vitro fertilization, an IVF cycle is the whole process where you take the eggs out of the body, get sperm and eggs to meet in the lab, and then the embryos are put back together, tested or not, and then put an embryo back in the uterus. From start to finish, getting DNA, building embryos, and then ultimately having the embryo get back into the uterus, that's a full cycle. The cycle length is dependent on what you're trying to do. So if you are doing a fresh transfer, from the time you get eggs lined up, it can take a month, about a week and a half of the eggs to grow, and then about 7 to 9 days for the eggs to come out, and then ultimately be transferred back. Again, 2 days for HCG, the retrieval day, 5 to 7 days of growth, and then putting the embryos back, you're often looking at a 1 to 2 month full period if doing a fresh transfer. However, if a person is cooling down from IVF because they were a bit hyperstimulated, they're waiting for PGT results, that can take 2, 3 months more. And then also, if you are having a pregnancy and then delivering and then wanting another transfer, you could say from the time you did the retrieval to the time of the next pregnancy, that could be even 5 years because you're having the extra children from having banked the embryos for things, or if you did for fertility preservation. So there's all kinds of timelines. Are there tests that need to be done before starting IVF? And that is an art. I can tell you in, the Northeast, a couple of other places where there's an insurance mandate, I think people get tested to death and there are all these copays and they spend a lot of money on things that really don't change that much of what they're doing. Now, again, some people say they're essential, and I'm not going to teach, the Leonardo da Vinci of a particular testing style to paint with a different brush. But I think most of what you need to understand for the woman's pelvis for fertility comes down to eggs, tubes, and uterus. And for us, where we do that single visit with a blend of ultrasound and hysteroscopy, I like the fact that you can know most of your fertility in 10, 20 minutes rather than 3 months worth of testing and tens of thousands of dollars. So I think there's definitely an art to it. I would say, though, that some people need extra tests, but I do find a lot of tests add cost without changing management in my world. And so if it's adding cost and save that money for decorating the baby room and the kids' college fund. I think there are a lot of ways of approaching it that are less intrusive and less expensive and faster. Can you choose the gender of your baby through IVF? And that's kind of a yes and no question. Now, first, make sure that you are not in an environment or a country which restricts your ability to choose what you do with embryos. There's some places that are trying to legislate that. What is really interesting is you could have babies born with lethal conditions if you are not adjusting for this. For instance, there are things like Fragile X. There are conditions where you can have muscular dystrophies that may be more likely with a boy. And so you want to find out whether the pregnancy has that, but also whether things are passed on. So this is very important to figure out as really a life or death issue for the future baby. There are a couple of things to think about when looking at checking the gender. So first, when you do IVF and then you do PGT, it's not just that you did IVF, but you have to sample the DNA of the embryo from the future placenta, and that genetic information will include the gender. First, it's not perfect, maybe 99% or so, but which is very good, but it's not perfect. So you always say anything we get for genetics, not 100%. Second thing is you say, if most people, only 50% of people bring home a baby with the typical US IVF cycle. So when people are saying, let's check the gender, most people are just saying, I just want a baby. I don't care, boy or girl, as long as it doesn't bark, I'm good with having the child. And so if you know the gender in advance, a lot of people are just going to say, look, I get to decide whether I have the boy or girl first, but ultimately the embryos will go back. And it's just a matter of sequence. So that's important. A third case, though, can be saying, let's say people are caring very deeply about gender. For example, the last of the line want to carry on the family name. I think there are ways of looking at how we value names in society, and it doesn't have to be a guy to carry it on. There are all kinds of things we could talk about that. But some people will not only look preferentially for embryos that are male, and you can be fooled. I had recently a person where 6 out of 6 embryos came back as male, unplanned. There's All of them wanted to be boys. She's going to be a boy mom. But also you can do a thing called sperm sorting, where you can actually send off the sperm, and then instead of it being 50-50 for boy versus girl, it can actually be 75-25 or 80-20, somewhere in that ratio, where you can actually influence the odds of what an embryo becomes. And you're not destroying embryos through that, you're just shifting the odds from the moment of fertilization. And then PGT would be able to tell you. So the bottom line is, yes, you can figure out the gender before an embryo goes back. One of the more controversial areas in our field is, what if I just want a boy, or just want a girl? Can I do IVF and have those embryos? Do I have to transfer an embryo of a gender I don't want? And I think we're going to get into some interesting ethics and politics here on this one, which I will not dive headfirst into. But I will say part of the answer is, I'm not aware of any law that would force you to get pregnant with an embryo that you do not want to put back. Doesn't mean that may not change, but I think we'll have some very interesting politics if there are laws that force women to get pregnant with an embryo they don't want inside them. Because what does that mean for putting back chromosomally abnormal embryos? What does it mean for putting back embryos that are highly likely to miscarry or have meaningful birth defects? So we have some complex politics that will continue to unfold as we unwrap that complexity. What is PGT? PGT stands for pre-implantation genetic testing. Used to be PGS, PGD, other things for sequencing or diagnosis. Quick thing is, PGTA is the most common approach to it, and it is checking for aneuploidy, which means, are the chromosomes normal? So you're taking some cells and saying, is the DNA likely to miscarry, or is it more likely to be a healthy child? One of the best questions you can ask is, how, as a spouse, can I be supportive of my wife as she goes through IVF? Several things. Look at it for each phase. First, throughout it all, there's going to be anxiety. This is existential. This is your family. This is your future. Being able to say, look, we don't know where things are, but we're doing our best. I hope it comes out positive. We're pregnant and everything's great. But even if not, I love you. I'm there for you, and we're giving it our all. That's the first starting point. Second thing, as you go through the cycle, know what are things that will happen at each step. First part, the period's going to be off, often with the medication to line up the eggs. If you'll have spotting, bleeding, or no period, it'll be variable. Just say it happens. Next thing is also the hormones will be shifting. You're going to go to a menopausal level of hormones often where the estrogen is very low briefly. That happens with Lupron, not as much with antagonist cycles, but a few days where the estrogen is low and there can be hot flashes and supporting through that. And then over the course of IVF, the estrogen can be 20 times its normal level at its peak. So you can go from very low estrogen to very high estrogen. And just saying, hey, these changes can meaningfully affect your equilibrium as a guy. Think what would happen if you went to no testosterone and then to having 20 times your normal testosterone. How would you feel hormonally from those level of shifts? The other thing I say for guys to imagine and do as much as you can to put yourself in her shoes is, everywhere you get an egg, you get a bruise. And so if you happen to get 25 eggs from the ovary, you get 25 bruises. And imagine one being sore. Well, now you've got 25, and more than that, it's on the inside. And so the intestines are rotating over them. They're constantly irritating that bruise. And so that she will need support and communication and listening to her and knowing that whatever she's going through, it's real. Finally, it ties into that. When you have the bloating from the big ovaries, as well as from fluid shifts, that can also impact constipation. So what happens when you give HCG or your trigger for IVF? So HCG mimics the LH surge. It's very much like LH in its structure. And there are other ways of doing it with Lupron trigger and other approaches, but HCG is the classic approach. And 35, 36, 37 hours later, the egg is ready to release, and that's when people do the retrieval just before the egg comes out because you don't want a person to ovulate. 35, 36, 37 hours later, you get the fluid out of the follicle, which is surrounding the egg, and hopefully the egg will come with it if it is mature. And then you go through each of the follicles and you get as many of those eggs as you can. And the size matters. And the larger the egg, the better it is. Somewhere between about 15 and about 25 millimeters seems to be the sweet spot for the size of a follicle. And then the lab will process it, put the sperm with the egg, and then allow an embryo to grow. Not every egg is mature or ready for sperm. Not every egg that is ready for sperm fertilizes. Not every egg that fertilizes grows. Not every egg that grows makes it to blastocyst. Of those that are blastocysts, not all of those have normal genetics. And even of those that test normal, not all of them are normal and not all of them will implant. So there's a lot of attrition to get that good, healthy embryo that hopefully makes the child. But a lot of people get there. And then for the last step, again, when you've got the healthy embryos or that appear to be healthy, that's when you end up arranging for a transfer where you give some estrogen and progesterone. And then you find when the lining is ready, you put the embryo back and you keep your fingers crossed, you hope and pray. Again, the nice thing is when an embryo has developed to day 5, instead of the 2-week wait, it's only 9 to 10 days because it's already has grown a bit past the day when sperm and egg would have met. So it's a little faster, but it's still a hard wait. Who is a good candidate for IVF? So, first of all, that is incredibly individual. And nobody should say who is a great candidate versus not without really taking the person who's going through it into account. Some people would see a 50% chance as horrible. Oh my gosh, there's a 50% chance I spent all this money and I have nothing. And there are people who see a 10% chance because of the low ovarian reserve as incredible. And they're saying, I am very much for that. And other people, they're 80, 90%. It's hard to get better odds than that. So there's a very much a range of what people get for what they do, and you want to talk to your clinician as to what they expect. The top things I look at first, sperm, eggs, uterus. You got to have the right DNA and you've got to have a good home for that future pregnancy. So, sperm, what's interesting is the lower the sperm count, often the better they do with IVF relative to other approaches. So, while it may not be the best sperm, it's still, if sperm and egg can finally meet, that's better chances. So that is a person with really low counts. They can both be a poor and a good candidate for IVF because it's not whether they had the best DNA, but what were their alternatives. Similarly for the eggs, the more eggs you have, the better off typically you do with IVF, providing you don't get into hyperstimulation. And the reason for the hyperstimulation mattering, people can be hyperstimulated and still do well, but a lot of people, when hyperstimulated, they take the eggs so early, they're a little bit less mature, they're a little less lower quality. And so you've got to find a decent balance for that. So sometimes for really, really bad PCOS, they may actually do worse with IVF than you would think. I'm not as convinced of some of the stuff on extra male hormone or other things that influence the outcome. I really think the driving force is just that people take the eggs too early and have to get a better balance for the stimulation. So that's a really important consideration, but that's an art. People have different opinions on that. And then the uterus. You have to have a good place for the pregnancy to go. So if the uterus is not healthy, even if you get great embryos, if there's not a good place for it to go back, that makes it hard. But so for highest pregnancy rates, I see top things with tubal ligation. They've been pregnant multiple times before, and sperm and egg just can't meet. And so they do well. Similarly, someone who's had the tubes removed for other reasons. What's interesting is if it's from PID or pelvic inflammatory disease, the scarring of the tubes and damaging and the removing of it, they tend to do pretty well. But if the tubal disease is from endometriosis, sometimes the endometriosis can scar and inflame the ovary, and it does worse. So it also can depend on the reason for things. Um, so having, you know, tubal factor is probably one of the best. And then another PCOS where you just couldn't get eggs to meet other ways. These are people often with a lot of eggs and good chances. And then the worst is running out of eggs. If you have no eggs, very hard for sperm and egg to meet, and you don't have a lot of opportunities to make embryos. Endometriosis that is not minimal to mild, but really this moderate to severe, I tend to see do worse for IVF, although a lot of that also relates to the eggs. And then sometimes really bad male factor, so really bad sperm quality. May need IVF to get pregnant in those settings, but that the male matters also, just like the woman does. The other things I watch for that can have a negative effect, smoking seems to, and excessive alcohol can be very negative. Excessive weight, especially as the BMI, not so much 30, 35, though people talk about that, but especially above 40, 45, 50 for the body mass index. That's where you can have some meaningful hits for things, even though it's all on a continuum. And then people with uncorrected uterine factors. Endometritis is becoming, as an infection, is becoming a big issue. Unremoved fibroids where they're causing a problem. There are a lot of things that can matter. Is IVF painful? I would say that it depends a lot on how you do it. The problem is you get out what you put in. And if you get out 3 eggs, most people are pretty quickly back to themselves. But the person who put in 3 eggs has 1/8 the yield of a person who got 23. And so what you want to say is, how do you balance the discomfort from surgery relative to the yield? And so that's the first thing. Second thing, that's just from bloating. Everywhere you get an egg, you get a bruise. You often have the ovary bleed into where it removed the eggs. And, you will feel worse from 23 bruises than from 3. That's just how it works. Then the question is, okay, what about during the retrieval itself? And that depends on what type of anesthesia they give you. And if you don't get anything, you just want to do hypnosis or, positive thoughts. Some people can do really well from that, but I can tell you if it were me, I would want propofol and to be much, much more comfortable. Still breathing on my own, but, I don't without intubation. But at the same time, the goal would be really just a deeper sedation where there is far less awareness or memory even of the retrieval. So depends on what you do. And then again, afterwards, it's not just from big ovaries that a lot of people feel, but also fluid can shift. And so it's important to distinguish big ovaries from fluid shifts and what you do for medication to minimize those risks, how you found a balance in the stimulation. But a lot of people, once they get past that, I find it peaking about 5, 6 days after retrieval. Once you start to get a week out, people tend to be on the mend. And again, that's an individualized discussion. Talk with your clinician as to what is the right number of eggs to aim for your best balance of yield and doing it once and getting it right relative to potentially needing to do another retrieval. How successful is IVF? You can have a place, for instance, with a 64% pregnancy rate from a single cycle of IVF. National average is 50%. I believe we're about 64 last I checked the numbers for women under 35. But it's not everyone is 64. It's that you will get 4 people who are roughly 80 and then 1 person who's 10 to 20 because they're borderline ovarian failure. And so there are a lot, so it's not just, hey, this is a clinic success rate, though you want high success rates, even though there are some differences among clinics. Um, but it's also um, what does a person for my circumstances, for the number of eggs I have, for where the sperm are, for where the uterus is, what can you expect there? And people can give you generalities. But nobody should ever say, oh, you're 100% likely to get pregnant. It might be able to say 0% if you've had both the ovaries removed or there's no sperm. But, for the most part, people should give you a ballpark estimate and then realize there are limits to what medicine understands. And sometimes people can be surprised. What are the common risks or side effects for IVF? So, top things I'm looking at for side effects, I think there's some bleeding leading into the cycle, some hot flashes if you're using Lupron, bloating, and then anything that can happen with pregnancy. That's the number one side effect. Not pregnant, miscarriage, prematurity, birth defects, ectopics, twins. If it can happen normally with pregnancy, it can happen with IVF. Now, what are some of the more obscure or less common risks? So first, infection. I would always hear about it. I can't remember the last time if I've ever even seen one from IVF. So it's very rare, even if it's non-zero. Similarly, bleeding. People will bleed a bit into their ovaries. Outside the ovaries, there will be some, but it's usually not enough that it would make you intervene. By the way, that some of the risks, it's not just that you have a risk, but why do you have the risk? And if there's a lot of extra weight, there's a lot of scarring in the pelvis where it's hard to see. These are people at higher risk relative to people where you can access things easily for things. And then risk for pregnancy itself. Again, I would look very much beyond the things I already just mentioned. Also, is there a risk for birth defects? And most of the risks for a pregnancy, for the baby being really big. You get that from PCOS. Do you have more risk for chromosomal abnormalities? That happens with diminished ovarian reserve. Is there a risk for, other types of birth defects, for instance, that can come with diabetes? Often these can relate, again, to underlying reasons. And while we do see some imprinting disorders, where when sperm are introduced directly into the egg, this is called a methylation issue. Again, a lot of these are 1 in 10,000, 1 in 100,000. And remember, for many women, if you age a few months, you may be increasing your risk for birth defects by that much as you get older. So it has to be also individualized where that balance of risk is. Also, again, people talk about risk for cancers after IVF. Much of my understanding for this relates to why there is a risk. PCOS is higher risk for endometrial cancer. Endometriosis is higher risk for ovarian cancer. Not having kids is a higher risk for breast cancer. How much of that would be attributable to IVF or any other fertility therapy relative to individual risk? My understanding of it is that most of it relates to the why you have a condition, not that you did the therapy for it. But again, that's something, if clearer data comes out, I would love to know it. But I think much of the risk is why you had to have therapy, not that you had it. Thank you so much for watching. And if you find this information helpful, please hit the like and subscribe button, ring that notification bell, share it with friends who are also wanting solutions and answers and control. And as I always tell people, don't suffer in silence. Get answers, find peace. We're here to help.